We're going to talk about alcohol and the heart and death and how alcohol damages your heart. And we cover alcohol and death in a more general term. Alcohol is a poison. That's it. It is a poison. It is the most widely consumed poison in the world. It is estimated that 39% of the world's population consume alcohol on a reasonably regular basis, which is a hell of a lot of alcohol. Most of that's in Scotland, obviously. I mean, obviously, the only take-home message you want to go home with is how much can I drink? I'll come on to that. There are tables like these things, you know, how much you can drink for men and women. And we think about units of alcohol. And that seems to be a fairly standard currency. Also, you would have thought. But a unit of alcohol in the UK is not the same as a unit of alcohol in Europe or a unit of alcohol in America. So a unit of alcohol, so this is all put into context, a unit of alcohol in the UK is 8 grams. In Europe, it's 10 grams, and in America, it's 15 grams, which means you can drink twice as much in America. You can do it by the unit count. It's one of those strange things. But it does mean if you are looking into the data on this, be aware that if it's recorded in units, you need to know where it's being written from, because it means different things in different countries. This is a confounding problem. Alcohol obviously can cause short-term harm. That's Amy Winehouse, very appropriately named, ironically, who actually drank herself to death, so that she died from alcohol poisoning. And alcohol, actually acutely getting alcohol poisoning is actually extraordinarily difficult. You really have to drink hard to do this. And the reason is, of course, is that alcohol is an osmotic diuretic. It's filtered by your kidneys and you just wash it out. And the more you drink, the more you filter it through your kidneys. Most of the alcoholics you do PMs on will have good kidneys because they've been consuming an osmotic diuretic in large quantities. But you wash it out. And that's why you get a hangover the next morning, because you're dehydrated. And that's what happens. So top tip, before you go to bed, drink a pint of water. Alcohol has a number of effects, you know, depending on that. That's equivalent to 50 to 80 milligrams per deciliter, roughly. Knowing that 50 is obviously the driving limit in Scotland and 80 in the UK. But even that, judgment and movement are impaired and you're less alert. And you're still allowed to drive. That's good. Once you get above that, slow reaction times, start to lose balance. And then coma and death is over that, so 300. So for most cases, you know, if you want to give somebody a cause of death as acute alcohol intoxication, you need an alcohol level in blood of about 300 to 350. In urine, it can be about 1.3 times higher than that because of the way it filters and concentrates in there if you've only got a urine sample. But that's the kind of level you want. But how do we record? So you've all had lunch, you're all a bit soporific. So we're going to do this by putting up hands. Okay, so I just want to get a feel for how you view alcohol. For people online, you can put your hands up, we just can't see you, but feel free to join in. How many of you have used, let's go through one at a time, these as causes of death? Or would use it as a cause of death? Acute alcohol intoxication. Lots of people. Alcoholic ketoacidosis. Yeah, that's good. Alcoholic cirrhosis as a cause of death. Good. Alcoholic fatty liver disease. Yeah, hundreds of that. Delayed death and alcohol misuse. Cop out. Yep. How many of you use alcoholic heart disease? Oh dear. Alcoholic cardiomyopathy. Yeah, okay, somehow. Good. Alcohol-induced cardiac arrhythmia. These are all ones that have appeared on death certificates. I'm not making these up. Nope. Cardiac failure due to excess alcohol. Okay, which is probably the same as that. But, those are all genuine causes of death. It's very interesting. You're all very happy about poisoning and livers, but you're not very confident about what it does to your heart. So, hence today's talk. So, does alcohol cause arrhythmias? Yes. It's been recognised that alcohol is a cause of arrhythmias. The most common one is atrial fibrillation. People who drink sort of red wine and port are prone to atrial fibrillation. They've usually got some underlying disease, but it's well recognised to happen. But in the 1970s, we also recognised a thing called holiday heart syndrome. And this are people who got sudden arrhythmias on holiday when they were binge drinking. Just binge drinking, if you're not used to drinking, will cause arrhythmias. Most of them are benign, some of them are fatal. And some people will die from cardiac arrhythmias at levels below the acute intoxication level because of this phenomenon of binge drinking and holiday heart syndrome. So you get increased admission rates to hospitals with cardiac arrhythmias after weekends and specific holidays, which are linked to alcohol excess. There's no doubt about it that it happens. But you get lots of different types of arrhythmias, and how these work is not entirely clear, but we do know it causes QT prolongation. You get changes in your refractory periods and your myocytes, particularly around the atrium. You get increased vagal tone. Long-term weight gain and increased blood pressure obviously increases your risk of a cardiac arrhythmia. You get slowing of your conduction velocities in your heart. So actually the heart, things are conducted less well. And long-term, you also get left atrial dilatation, but that's probably secondary to the changes in the left ventricle that happens. And there's no doubt your arrhythmogenic risk acutely goes up by the number of drinks you have. The more you drink, the more you likely get arrhythmia. There's this wonderful study I found called Munich Brew. And I'm sure Rob hadn't participated in this. Rob had been here, he would have got a lot of the butler jokes here. But essentially, they got the people at the Munich Beer Fest cardiac monitors. A whole mass of data about what was happening to their heart rates during all of this. And they found the commonest things are premature atrial contraction. So you just get a funny extra beat. And that's fine. That's of no consequence at all. You will all probably have them occasionally, whatever. It doesn't really matter. But if you increase them and the frequency goes, you're likely to trip yourself into atrial fibrillation, which is not necessarily what you want to do. You don't seem to get supraventricular tachycardias from alcohol particularly, but you do get atrial fibrillation both from short-term binge drinking and long-term alcohol excess. And obviously atrial fibrillation, if you've got a poor heart already, is not a good thing to do because it'll drop your cardiac output by about 20% because you don't get the primary action of your atrial contraction going on. Premature ventricular contractions are reported, but we don't know what they mean. But then you get ventricular arrhythmias. You can get ventricular tachycardia and ventricular fibrillation from binge drinking. So binge drinking in itself is dangerous even before you do anything else. So far, I've not had to say an acute arrhythmic event following binge drinking as a cause of death. But I would do if I had to, if I had really nothing else to go on. Then somebody who fitted the right demographic and right history to do that, I would certainly use them. And there's no doubt from the evidence that some cardiac death is increased in populations following binge drinking. And that's not because they've got acute alcohol toxicity, where the reports have actually measured the levels. There just is an increase in death. And also, some cardiac death is increased in people who have chronic alcohol excess. Anybody want to drink? No? Good. I will tell you how much you can drink later. It is a very important cause of mortality across the world. There's some very interesting hotspots: Greenland, Russia, Finland. We do okay. We're lower than the United States, about the same as Canada. And obviously, the Middle Eastern belt and sort of Saharan Africa doesn't get much. China doesn't appear to have much, but then we don't really know what happens in China anyway. But this is from global disease reports. But it is estimated that alcohol is involved in 2 to 6% of all adult deaths across the world, which when you think about only 39% of the population dying are drinking, that means it's probably up to 10%. I can't believe that you put 10% of your deaths down to alcohol overall. So you're underestimating that those figures aren't very good. What are the death rates like? So this is the age standardized alcohol-specific death rates, and it's from the BBC, so that's correct. There's no bias in it. But actually, it's going up, and it's sort of gone up since COVID, interestingly. More people are staying at home and drinking more because it's cheaper to do that than go out. That's the sort of sociological argument that's being used to explain this away. But we've now changed our drinking patterns to going to the off-license, buying a load of wine, and sitting at home silently drinking ourselves to death. But it's a worrying trend for what's happening in the world. But are there health benefits to drinking? Yes, of course there are. Okay. So if you look at this hazard ratios for long-term alcohol consumption, it's what's called a J-shaped curve. there is a sweet spot about how much you can drink, okay? And it works out at roughly 7 standard drinks per week, and that's UK standard drink, so that's 8 grams, not 15 grams in the States, okay? So 1 glass of wine per day on average, that's your lot. That's where you want to hit the sweet spot. If you go up to 2, you're going to be probably okay. For men up to 28, well, okay, high risk of atrial fibrillation and other things, the standard cardiac test thing up. For women, it's 21, instead of 21. Again, you would increase risk of various things happening. So at the moment, you know, about 1 drink a day is about all you should have. So I think I did my week's work last night. So that's it. Different drinks have different effects on them. Obviously, there are things that are better for you and things that are worse. Wine is generally better than either spirits or beer. Sorry, Rob. He's a beer drinker. And red wine, probably because of the antioxidants, is the best of all. So a glass of red wine, particularly good. And Riojas is supposed to be particularly good for the amount of antioxidants. This is a wine tip for you. But the long-term effects are rather more concerning, because alcohol long-term has effects on your heart, your brain, your bowel, and your liver, and causes disease. And particularly the ones in the liver and the heart are the ones that actually will kill you at the end of the day. So we'll just look at some of those things. The cardiovascular effects of drinking too much alcohol on the time is high blood pressure. So whilst we try and separate out, you know, different causes for our big hearts, as we said, there's a huge overlap about how these things happen. So you're more likely to get hypertension. You do get more coronary artery disease, and that's probably related to other factors that go along with drinking as much as drinking itself. There is evidence to suggest that, again, low-level alcohol is actually beneficial in terms of your coronary atherosclerosis, but again, it's at about the drink a day level. That's that. And even that's sort of controversial in the literature. You're more prone to strokes, but that may be related to high blood pressure, high incidence of peripheral vascular disease, and you get cardiomyopathies. So if you look at hypertension specifically, if you drink a low amount, there's probably little effect. But once you start drinking more than about 5 units a day, you get increased in diastolic systolic blood pressure that is measurable at 4 to 7 millimeters of mercury in time, which may not seem like a lot, but that is an, you know, a significant change in your baseline that you don't want to have. So in terms of how does alcohol and hypertension cause this, well, this has an effect on, let me disconnect the next something. Okay, good. Has an effect on endothelial nitric oxidase and alters endothelial cell function. It also alters vasomotor tense. So whilst you think alcohol will actually relax you, actually it doesn't. It's causing your vasomotor tone to go up and causing your hypertension. So it's not relieving that stress at all. It's actually compounding. You just don't think you're in stress anymore because you're just. So there's that. So all these things actually work against you to do that. But alcohol has that effect on your endothelium, and you can't relax your blood vessels terribly easy. Again, as we said with coronary artery disease, low levels may confer some protection, but less so in women. Sorry, but that's just the way it is. I don't like this stuff. But higher levels of alcohol, despite this myth that alcohol, you know, protects doesn't, at higher levels, you have an increased risk of coronary artery disease and increased risk of stroke. And again, you have this J-shaped curve, and you're looking at the alcohol consumption per day there. So we're looking at 1 or 2 drinks to get the maximum benefit in both men and women, and then after that, it goes downhill after that. At low levels, so we know that things increase your background systemic inflammation are bad for you, they increase your atherosclerotic risk. Atherosclerosis is driven by low-level inflammation there. But low levels do decrease systemic inflammation. You're less inflamed when you've had a little drink. I certainly am. But low levels, you lose that beneficial effect. But even at high levels, you start to get increased platelet aggregation, just in the same way you do with stress. And so you've got more sticky platelets flowing around, you're more likely to get microvascular thrombosis and clot progression and all sorts of things like that. So on coronary artery disease, yes, it has an effect, some protective, but long term, it's going to do you some harm. But on your brain and your heart, you do get some cardioprotective effects. So you get changes in platelet activation, oxidative stress. This just summarizes really what I've said about all those things. We'll move on from that. So you can demonstrate this in animal models. that you get direct myocardial toxicity. So alcohol actually damages your cardiac myocytes. Whatever it is. You get increased oxidative stress, you get increased lipid peroxidation, which damages your mitochondria and also damages cell membranes. You get more apoptosis. You can see increase in myocyte, cardiomyocyte apoptosis in mice. You give them alcohol, so they're basically losing their myocytes. And I presume, although we've not done, can't really do the test, that that's probably going to happen in the human as well. There's no reason why it should not. You get upregulation of your neurohumeral axis, so you're stressing your heart by increasing the amount of sympathetic activation, which puts in hypertension, but also drives your heart harder. So do that. And because of the oxidative stress, you get mitochondrial dysfunction. So like so many of these other things, you use your energy substrates less efficiently. You get the electron transport chain gets disrupted. So you can't actually use the energy you get. Cardiac myocytes are very useful, are very clever cells. They can actually use alcohol as an energy substrate directly. So you can actually feed your heart with alcohol. You'll use it as an energy substrate, but only to a limited extent. You can't do it in any other way. There aren't many organs that can do that. The liver will process it mostly, but otherwise, yeah. You get increased fat within cardiac myocytes with prolonged excess alcohol, and it also stimulates fibrosis, probably through activation of the neurohumeral axis and renin-angiotensin systems, which seem to drive fibrosis in the heart through TGF-beta. So it's a poison to your heart. So human studies, there is no doubt that chronic excess alcohol is bad for your heart and creates a dilated cardiomyopathy phenotype. So as you've seen and we've discussed this morning, on echocardiographic criteria, you will get eccentric left ventricular remodeling and increased left ventricular mass. And if you stop drinking, it is reversible to some extent. But if you don't stop drinking, you will progress to a dilated cardiomyopathy and all the problems of heart failure and arrhythmogenicity that occurs. So, you know, we see dilated cardiomyopathy. We see it commonly. You know, what's it due to? Well, some studies say it may account for as many as 3 to 8% of dilated cardiomyopathies. One study, which is in northern Finland, which has a peculiar vodka problem. It does have a very high incidence of alcoholism and a high incidence of alcohol-related deaths. But in northern Finland, and the data is good, some studies suggest 40% of dilated cardiomyopathies are due to alcohol. So it's going to be somewhere between here. And it's been implicated in 16 to 19% of sudden cardiac deaths, you know, due to either arrhythmogenicity or due to dilated cardiomyopathy and go on. So the fact that most of you have never, or very few of you, reported a death, an alcoholic heart death, probably means we're underreporting this to do that. And another study I looked at showed that in non-ischemic sudden deaths in the age group 40 to 59, it's thought that alcohol had contributed to a quarter of this. You know, we are calling them other things. 7,000 autopsies, 17% of dilated cardiomyopathy attributed to alcohol. And if you have an alcoholic cardiomyopathy, you have a high risk of sudden death. So once your heart has failed, then you have a risk of sudden death that goes up. So it is extraordinarily dangerous stuff for your heart. How are we going to define this? I mean, clinically, it gets defined like any other dilated cardiomyopathy. So you have a dilated LV with thinned or normal LV wall thickness, so essentially eccentric hypertrophy, as we've defined it before. And the increased left ventricular mass is increased, and the ejection fraction goes down, which is what happens in dilated cardiomyopathy. Part of the compensation of dilatation is that you're maintaining cardiac output at the expense of ejection fraction. That's how it works. When you look at the clinical studies about alcohol history, what they are usually reporting is 80 to 90 grams a day, which is probably the equivalent of a bottle of wine a day, which may not seem like a lot. If you do it every day for that, and they usually need that to be for 5 years. Now, when I'm looking at this now and thinking what I see, if I see a GP's notes that says alcohol dependence for more than the last 5 years, then they've probably been drinking at a level that could cause significant heart disease. So I'm always looking at those GP records. So when did they start, or when did the GP first recognize alcohol dependence? because you'll sometimes get a snapshot of how many units of alcohol they're having in a week sitting in the GP note, but you don't know what that is. But if they've been dependent, and there is evidence to suggest that yes, at least 5 years, but if you're doing it at a lower level for 10 years, you may also be at risk. So it's a bit like smoking, where we have pack year histories. This may be, bottle year histories or grams of alcohol year histories, however you want to express it. But you get an accumulative damage. It can reverse before you get too much remodeling of your left ventricle. So how do you end up with the dilated cardiomyopathy? Well, we know chronic alcohol growth will stimulate cardiac fibrosis directly, probably due to myocyte damage and myocyte apoptosis, and therefore you get fibrosis. To do that, you've got increased oxidative stress, which damages the cells, but also damages the heart pathway. So if your heart muscle cells, individual cells, can't beat as efficiently, they'll invoke Starling's law, cells to be stretched further so they can contract harder. But you end up with a dilated heart because of that. So you also need decreased ejection fractions and contractility, which leads to that. And then secondarily, you're going to get all the things that cause hypertension and cause a dilated cardiomyopathy as well. It's actually very hard to separate out a lot of these different sort of metabolic type heart disease and just categorize them into a single thing, because most people have a bit of everything. So one study suggested 12 to 13 grams per day. Well, that's 2 glasses of wine, essentially, per day. It was over 5 years, and this one would actually lead to that. I suggest it isn't as little as that, because if it was, there'd be an awful lot more people with dilated cardiomyopathy and alcohol than there are sick. So we don't know what the precise figures are. So you have to make your own judgment about this and recognise that most people lie about their alcohol consumption. Oxidative stress is something that seems to come up. I mean, whether you're diabetic or hypertensive or obese, you get oxidative stress in your cardiac myocytes, and alcohol is just another one that does this. So you get dysfunction of your sarcoplasmic reticulum, so that's where your calcium is stored intracellularly, and your whole calcium movement across the membranes is impaired, which affects your contractility. And then you also damage your mitochondria, so you get reduced mitochondrial function, reduced ATPase activity, and it just goes to tits up. It really does. So it was quite a wake-up call to read just so much on this stuff about how damaging alcohol can be to your heart. I had to have a drink after reading that picture. Activates apoptosis. You can see morphologically that's going on. You see loss of cross striations in the myocytes. That's there. They're quite difficult to see, but it does appear to happen. Pycnotic nuclei and swollen mitochondria, if you bother to do EM on them. And the mitochondria lose the way in which they are energy handled and traces of mitochondrial protein excess. And these are constant, seem to be themes about how myocytes respond to damage, because you see it in hypertension, and you see it in diabetes, and you see it in alcohol. So that internal working and energy and calcium handling functions that are absolutely important for cardiac myocytes seem to get destroyed by all these common pathways. Of course, other organs are affected by alcohol, which will have a bearing on the heart, although, as you'll hear, you obviously realise the heart is the most important organ of all. But liver cirrhosis associated with pulmonary hypertension, so that will cause increased workload on your heart. Also change your systemic and spinal vascular resistances associated with it. If you get chronic pancreatitis and malnutrition from that, absence of B vitamins, thiamine deficiency, phosphate and zinc deficiency, and diabetes also have an adverse effect on your heart. So these things are all co-founders. Atrial fibrillation, as we mentioned, the hypertension. So all these things are coming together to damage your heart. But it's not, it is a combination of those secondary effects and the primary effect of alcohol on your heart that can lead to a state of alcoholic cardiomyopathy. So we come back to the original question. How many, we've all agreed you probably all use the ones on the right side, left side, if not. How many now would record this as alcoholic heart disease? Nobody, I haven't convinced anybody to do this. One, alcoholic cardiomyopathy. Okay, people are getting engaged. Alcohol-induced cardiomyopathy, possibly. Cardiac failure due to excess alcohol. Okay, I think alcoholic cardiomyopathy is fine. I mean, I think genuinely that's where we need to be parking this. You know, if you've got the right clinical history to do that, then you should be doing that. So acute alcohol intoxication is quite easy, 300 to 350 milligrams per decilitre. You've got to work hard to do that. It's usually spirit drinkers who get to that stage. Alcoholic liver disease, I mean, we're all happy using alcoholic liver disease for that. You can either have cirrhosis or moderate to severe fatty change. Deaths are likely to be metabolic. If you haven't actually got overt hepatic failure with ascites, portal hypertension, jaundice, it's probably metabolic. We know you get a lot of disruption or changes in your key homeostasis of sodium, potassium, and magnesium. So if you look at non-alcoholic fatty liver disease, they often get hyponatremia way below 120. Well, the normal is what, 135 to 145. And that's at a level, once you're below 120 or 118, you're at the stage where hyponatremia will cause comas. And that's recognized to happen with non-alcoholic fatty liver disease, and it happens in alcoholic fatty liver disease as well. Magnesium seems to be something that gets very disrupted with alcoholic liver disease, and yet it's something we don't routinely measure in our electrolyte screens. And there are some people advocating we should pay more attention to magnesium than we do, because it functions very much like calcium, which we know is important. Yeah. So some unexplained death in alcohol misuse is a recognised entity, and is obviously a diagnosis of exclusion, where you've got morphologically normal heart, liver changes but not severe, so mild degree of steatosis, you haven't got cirrhosis, and you've got to separate it from SADS because of the genetic implications of that, and you've got to have a history. It's usually an older age group than SADS, so it tends to be in the late middle age and late middle age, more commonly men, and it seems to be associated with a high incidence of psychiatric illnesses. Now, whether there's a confounder there or whether the psychiatric illness is the one that means they're alcohol abusers, I don't know. It isn't entirely clear. So I've used that on a couple of occasions, but it is very much a diagnosis of desperation when you use it. So diagnosing alcoholic cardiomyopathy, it is a real entity. I'm quite convinced of that. You need a history of excess alcohol for more than 5 years if you're going to use this. I think less than that, you'd be on slightly thin ice with that. It's a morphology of a dilated cardiomyopathy, so the eccentric hypertrophy, increased mass, normal or thin wall thickness, and no evidence of significant coronary artery disease or valve disease, bearing in mind that you get functional mitral and tricuspid regurgitation in dilated hearts come what may. So, you don't have mitral stenosis, but mitral regurgitation things happen because your heart's there. There aren't any specific histological features. It's a bit like other things. You get a bit of fibrosis, perivascular, interstitial. The myocytes can be a bit vacuolated. They can have fat in them, but there isn't something that you can look down the microscope. This is alcoholic dilated cardiomyopathy. It's going to be based on history and the absence of other things, and obviously negative toxicology for this. Then if they're ketoacidotic, they're ketoacidotic, and that's that. But I think it is a diagnosis to be considered. I think it's a diagnosis should be used, and I've certainly used it since I did this research for this as a way. So in terms of alcohol intake, this is the most important slide for you. 1 to 2 units a day seem to have some health benefits. Okay, red wine's probably the best, and it's probably best not to do this every day. So people say 4 days on, 3 days off sort of mentality about this, and don't binge. Binging is bad. So don't go for doing all your alcohol for the month in 1 day. It's not a good look to do that. What's happening in the future? So we talked about various other sorts of heart disease. We've always used ischemic heart disease as the mainstay and the default position for all our causes of death because it's easy and we think we know what it does. If you look at the transplant world now and cardiac transplantation, we very rarely transplant ischemic heart disease because the treatment's got so much better. That doesn't mean they don't die from it, but they're not dying suddenly. They've got known disease. Early intervention in PPCI means we're limiting infarcts. We're seeing less people with heart failure from ischemic heart disease than other causes now, because limiting infarct size means you're not affecting cardiac function as badly. We're getting people stented, so their coronary arteries stay open to do that. So we need to be looking and thinking, well, these people are going into heart failure, and there's probably something else going on. And I think we underestimate what it is. And I think what we should be concentrating on as pathologists are in the 21st century is not the ischemic heart disease. Yes, it's still there. It's still going to be part of what we do. But I think we need to actually be thinking, and I sadly have done talks on all four of these, that actually the thing that scares me out there is hypertension, obesity, diabetes, and alcohol. And the difficulty is they overlap. If you're diabetic, if you're more likely to be hypertensive. If you're obese, you're more likely to be diabetic and hypertension. Or obesity could be because you're drinking. They're all interconnected. But what we're seeing is a different pattern of heart disease. And I don't mind writing hypertensive and diabetic heart disease and obesity as a cause of death, because you've got to summate it in some way. As I've said to you before, then things you put down into 2 don't often they get recorded, but they're not really used by the ONS for informing health policy. So every time you put diabetes down in 2, it doesn't get used. You've got to get these things up into 1 for them actually to really impact on health policy. So we're missing out on a lot of stuff by doing that. To do that, and it's with diabetes. I think when we talked about diabetes, it's very much don't think about it as just a risk factor for coronary artery disease. It is actually a risk factor for your heart in its own right. So I think 21st century heart disease is on the right side of that slide, and we're moving away from ischemic heart disease because of these things in statins. And actually, we may get past the hypertension moving across if the combined pill of a statin and 2 antihypertensives for everybody over 50 becomes standard health policy. And there would be a very good case to make for that. So that's where I will leave it and take any questions. Thank you.